Hello, I'm Dr. Dale Michels, and this is Talks with Docs, sponsored by the Lancaster County Medical Society. Joining us today is Dr. Steve Martin, and Dr. Martin is a cardiologist with the Nebraska Heart Institute here in Lincoln, and we're going to talk about some interesting things that are being developed and a little bit about a different part of heart disease than we usually talk about. I think everybody understands heart disease and everybody thinks of coronary artery disease when they talk about heart disease, or they think about electrical issues when they talk about it, but we often don't talk a lot about valve disease and how that affects the heart. So, Dr. Martin, thanks for coming and thanks for joining us. Let's talk a little bit about this issue of valve disease versus the coronary artery disease. We have a little heart model here to kind of show the differences. Talk a little bit about the differences between those three sorts of things.
Well, first of all, thanks for having me on, Dale. I love to talk about heart disease. We all are aware of artery blockages, and these are the arteries that come across the top of the heart, and the aorta comes off the heart, and the very first arteries that the aorta gives off go right back to the heart. That's sort of heart attack issues, and we all know about that. We all hear about that quite a bit. We also know that the heart needs an electrical supply, and we hear about pacemakers and defibrillators and things like that. What I'm talking about today more is the valves inside the heart. The aorta, which is the large artery that first comes off the top of the heart, gives off branches that go right back to the heart, and those are the red and blue branches that you see draped around the top of the heart. And the heart has electrical supply that you can see, the white stripes there. The heart also has valves, and a lot of what we're talking about today is actually the valvular disease of the heart. 4 different valves of the heart, each of them can have their own problems, like the mitral valve or the aortic valve. These can often deteriorate and cause a significant degree of problems for patients, and it's becoming increasingly common as we're getting an older population.
Yes, people live longer. If they don't have the other kinds of heart disease, then oftentimes the valves start to malfunction and create the problems. Well, tell me, how often does this occur? It seems like I hear about it more often, or I listen to it with my patients a little more often than I used to.
Yeah, it's about 5 to 10% of folks over 80, a little bit more common in men. And interestingly, the same risk factors, particularly for aortic valve disease, that will cause coronary disease, also cause aortic valve disease. It beats up on the valve and causes calcium deposits, and so that's
things like smoking and the things that you and I have been talking with our patients about for all these years, same kind of problem that leads to the aortic stenosis.
Absolutely, absolutely.
Now, usually, at least in my experience in the past, the first time I'd find out that a patient might have aortic stenosis is just when I listened to them with a stethoscope. Are there any real symptoms that people ought to be thinking about to say, well, maybe I have a problem?
Yes, well, I think it's always important to have your doctor listen to ask them if you have a heart murmur. Ask them what are you hearing there. They'll tell you. Some people are born with an abnormal valve. They have 2 leaflets instead of 3 leaflets, and they get this disease, aortic stenosis, much earlier in life, usually in the 40s or 50s or 60s. The valves that I deal with mostly with the non-surgical implantations are usually in their 80s, and that's the calcific aortic stenosis valves. And again, hearing the valve with the stethoscope is the first thing. And fortunately, what we watch for symptoms are shortness of breath, chest pain, or lightheadedness. And those are the first 3 big symptoms that we really pay attention to.
So a lot of times patients may have some fairly significant aortic stenosis and really not have any symptoms.
That's right.
It's just with us listening. Yeah, I tell my patients it's kind of like when you step on the hose and it starts to make noise. That's what I hear when I hear a murmur, is that little extra sound. And that's my clue that maybe that we need to do some extra studies. Yep. So tell me, how is aortic stenosis diagnosed after you listen and you hear the extra sound or the murmur with the stethoscope? Then I send them to you, and what do you do next?
Oh, we always do ultrasounds or echocardiograms, and that's really the best way. This valve's pretty up front, so it's pretty close and easy to get to look at with an ultrasound of the heart. And we look at the pressure across the valve and the velocity of blood flow through the valve, and we're able to tell how tight it is based on that. But just because we know how tight it is doesn't necessarily mean that we have to move on it and do surgery on it or some kind of opening of the valve yet. We just are able to track it over time.
Okay. And so some patients may show up for the first time with a fairly tight or narrowed valve. Others just maybe have a little narrowing, and you need to watch for a period of time just kind of to see what happens with them. And so you do an echo or an ultrasound, as you said, and there are a couple of types of echocardiograms. Let's talk just for a second. The one everybody's familiar with is when they put the goop on your chest and you rub it around. But we also do some other types of echocardiograms. Talk a little bit about those.
Well, there's the echoes called a transesophageal echocardiogram, which is an echo where they numb the back of your throat and they have you swallow this black tube. It sounds unpleasant, but it's like an endoscopy, except it doesn't have a camera on the end, and they don't go down to the stomach. They just go halfways down, and they have an ultrasound probe, and they get gorgeous pictures of the heart because there's no bones or lung tissue in the way. That esophagus, the food tube, is right up against the heart and just gets beautiful pictures.
So if for some reason they can't do it with the regular ultrasound, the cardiologist may recommend that you do the transesophageal and just double check to get it. Certainly don't want to go through an operation or anything if you don't have to. So it makes some sense to make sure that you exactly know exactly what's going on. Tell me a little bit about the time frame average. I see a patient, they're 81, I hear a murmur, I send them to you, they have a little aortic stenosis. Do they all progress at the same rate, or do some of them never progress, or tell me?
Well, they all progress, but they all progress at a different rate. So the first time we see somebody, we usually like to get that echocardiogram, and provided that their pressures are below a certain level, we're comfortable with saying, let's do it again in 6 to 12 months and just see how fast you progress. We know there are certain numbers that we pay attention to, but we're really honed in on these symptoms. It's interesting because once they get those 3 symptoms we talked about, shortness of breath or chest pain or lightheadedness, then we really have to start thinking about moving because their prognosis is pretty poor after that develops.
So they aren't going to do very well if we don't start taking some action once those symptoms start to develop. So if you saw a patient with aortic stenosis and you said, let's see you back in 6 months, but in 3 months they started to get those symptoms, they shouldn't say, well, he didn't say to come for 6 months, so I'll wait. No, they need to come see me, or they need to come see you and get it figured out as to what's going on.
Exactly.
Well, now, in the past, as I remember it, aortic stenosis was, if it could be repaired, was almost always repaired with open heart surgery. Incision in the chest, cardiac bypass, and they would go in and they would replace them. There are a few patients I remember that they would sometimes put a tube down or something through into the heart and actually spread open the valve a little bit again. Is that still done?
Yeah, that's the balloon valvuloplasty, and anytime we do one of the new procedures, we'll use that balloon valvuloplasty technique before we put the valve in. So it's still done on occasion. Now we reserve it for patients who we're not sure if they're even going to be able to make the ability to have the percutaneous valve put in. So we'll sometimes do that just to see, will they get better enough? Will they be able to walk better? Will their kidney function get better? Will their lungs get better? Can they even handle this new valve?
So sometimes that's kind of a staging procedure to balloon it and stretch it open and see what happens and see if they can do okay.
But never done definitively, like that's the definitive treatment.
That's just the temporary. That's a temporary thing at best in all cases. Okay. And the old-fashioned open heart surgery with the valve, they usually use, some of them use mechanical valves, some of them use valves from, I guess what, pork?
Pig valves and cow valves, both.
And they've had a fairly long history now of using. So let's talk about some of the differences between this old technique of the open heart and the chest splitting and some of the new things. Talk about a little bit some of the differences.
Well, our surgeons are very good, I mean, around the country. And so there was the way that this valve came to be was there was a population of patients, maybe 50% of patients who were just inoperable. Just the surgeon said, they're not going to get through surgery. I can't do them. And so this whole procedure took that population of patients that had no options. And they divided them in two and said, okay, we're not sure if this valve is going to work good or not. Let's try this new valve that we put in from the skin to see how people do versus medicine. And of course, this valve had really dramatic survival advantage over doing nothing like you'd expect. This differs from the open chest procedure where they saw down the middle of the chest and open the sternum, and that we're able to go through either a space in the groin like a heart catheterization, or sometimes even to the tip of the heart, or even to the aorta up underneath the clavicle with a very small incision, and then go in with the catheter that's probably a quarter inch almost in diameter, a little bit smaller than a dime, I would say, in diameter, and be able to put our equipment in through that portal and go in with the balloon and blow up what is essentially a stent with a cow valve sewed around the stent.
I see. So it's got the opportunity for the people who in the past we would have had to say, well, we'll do the best we can with the medicines we have. We really, and doing the best we can only helps the heart maybe work a little better for a time. Because of course, if the heart has to keep working against a tighter and tighter valve, the heart tries to get bigger and it works harder and doesn't do so well sometimes from that standpoint. It becomes ineffective just because of that little narrowed opening. And normal size of aortic valve is what? Maybe nickel, quarter, somewhere?
I would say probably more like a quarter.
Quarter, and some of these when they get down are more like pencil eraser tips
they're
when they get
tight.
to the
quite tight.
when they get down to the real critical ones. So there can be a gradual but fairly big shift, and you can certainly see why the heart would have to work a lot harder just to pump against the pencil-sized thing versus
well,
the
if for instance, if your blood pressure was 120 or so when they measured the arm, inside the heart muscle itself, it might be 240, 250 in some of these patients, so it's quite high.
So it's very high, and therefore the heart wears out
a lot of
real
work,
quick. Yeah, a lot of work. Okay. So let's talk a little bit about some of this new procedure and how it works, and give patients or families a little idea about what's being done, how it's done, and then we can talk about a little bit of the potential side effects and how we have to take care of them afterwards later. But talk a little bit, because it's relatively new. I don't think it's been around for more than, what, 2 or 3 years or less?
Yeah, it's been around a little bit longer in Europe and the United States. It's been about that long that we've been putting the valve in.
Okay.
And it's an interesting procedure. I think most people understand stents as they open up artery. They're like sort of like a metal cage or fence that opens up the arteries. The way to think about this valve is that it is a big stent. It just is different in that it doesn't have just an open stent, but it actually has the valve leaflets sewn on the inside. And there's an example of that in front of us, and you can see the skirt around it, the stainless steel frame. To implant this, this whole valve is crimped on to a large balloon. Obviously, we don't intentionally make it large. We make it as small as possible, but it's a bulky device. It's
bigger than the balloons we do with the stents for these little tiny arteries.
Yeah, these guys are nothing, because those are easy. We can go through the wrist and put those stents in, but this one you need to have a big vessel, and you need to have a surgeon. And that's what's different about this approach is for the first time, and I think from here on in the future, most of these cardiac studies, ironically, that seem less invasive, have about 6 or 7 doctors in the room, because I need the surgeon skills to get in there. He needs my wire skills. I need my anesthesiologist to be on board. I need my imaging cardiologist to be on board. And so there's a lot of us talking. It's a pretty well choreographed dance. It's not just one guy's doing the surgery or one guy's doing a stent. It's really a team. So that's and it's been kind of fun to do that too, because you get the best of everybody's skills, and then as you're going through the procedure, everybody does their part. So first thing is you access, and you either access to the groin, or you'll access to the tip of the heart, or again underneath the clavicle, and then you'll put a wire, and it goes around the aorta into the heart. You balloon it open first, and then secondly you go in with the valve crimped on to the balloon, and that's where the tricky part is. This is where we need our imager and to help us. We need our anesthesiologist to get our pressure just right, because when the heart's not stopped, they're not on a heart-lung machine. So we then pace the heart real fast so it quivers and doesn't move around a lot, because we need it to sit still for just about 20 seconds. And then everybody gets to give their input real quick, and then we just blow the valve up over the course of about 10 seconds, and then the blockage is gone.
So it just stretches that metal into place, and once the metal is stretched out, it stays in that position. but you got to make sure it's not too high or too low,
Yes,
or
yeah,
all of those sorts of things. So it really is a much more of a team approach. It's not the sort of thing that a cardiologist by himself is going to be able to do, like they used to do the appendix on the dining room table. Those days, of course, are long gone. And in cardiology, it takes a bigger team. Everybody has to be working together and do their part to get this done.
I think you think intuitively, oh, less invasive. Hey, one guy can do this. And it's like it's almost opposite. Because it's less invasive, it's sophisticated. It actually requires the team to really get along and do it well.
So there's a fair amount of work getting everybody ready. And
yep. Probably 10 hours outside the operating room for every 1 hour in the operating room. That's the interesting thing too. These are done in a special room. It's not a heart cath lab and it's not an OR, it's a hybrid. It can do both. And you have to be able to do both because you may decide during the middle of the procedure we need to convert this to an operation.
So there is a possibility when somebody undergoes this, if this just doesn't work, you may have to try and go in and replace it with one of the older fashioned or the older style of mechanical or pork or beef valves, whatever it is.
And in fact, this is a bovine or cow valve sewn onto that ring, so it's kind of interesting. It's the same one that the surgeon puts in. It's just attached to a stent.
It's attached to a stent. And
a lot of people ask me, how does that stay in there? And it's because that metal frame hangs onto that calcium, and you can't take it out if you want to.
So once it's lodged, it's there. It's stuck. Sometimes in reading about this, found that a few of them leak a little bit, at least when they first started to do that. And I assume that's because the calcium is so thick or stiff that you can't really get that valve pushed out against it.
And irregular sometimes. You'll have literally a stalactite, we call them, in the cath lab, where one piece of calcium pushes it away a little bit. So it's not perfectly a spherical or a round hole. It's a little bit ovoid, and you'll get a little bit of a leak. So we're always concerned about those, but we've been pretty lucky so far.
Yeah, and I think the average person doesn't think about the inside of the heart as having stalactites and stalagmites. But I understand what you're saying, that the calcium that's there and that valve that's made that valve not work in the first place certainly creates a problem. So what about treatment and recovery? Tell me a little bit about that. This is certainly different than somebody putting the old-fashioned incision on your chest.
A little faster recovery. Some people are remarkably fast, where they will, they'll be ready to go home by almost day 2. But a lot of these people are older, and we got to keep in mind that some of them were inoperable, so they didn't even have we wouldn't have had a chance. God forbid they did go through an operation. If they would have made it, they might have been there for a month. So they do stay, most of them stay 4 to 5 days in the hospital recovering, usually from the access site, and just recovering, getting their strength up.
Yeah, it's obviously a big shift. Number one, their heart doesn't have to work so hard suddenly, so that takes some readjustment. And number two, they do have better blood supply because everything's kind of working differently than it was. So yeah, I remember one of my patients a number of years ago, it was probably 10 to 14 days, kind of typical for the old-fashioned valve in an older person, just because of all of those other issues. So what about blood thinners after this? We all know about having to take blood thinners, Coumadin or warfarin, and injections and that sort of thing. What about those with this?
Well, there's still new information coming out about it, but we're finding out actually that they do pretty well with very minimal blood thinners. Ironically, it's a very big stent and it's wide open with a tissue valve. So we usually just put them on aspirin. We put them on another platelet agent called Plavix sometime for a few months, but then after that it's just going to be aspirin. So
initially it's kind of like the other kinds of stents. The mechanical ones, of course, had to stay on Coumadin or warfarin or one of those, but the ones that came from animals, they would be on it for a short term until everything gets kind of healed up and adjusted. And do we have any ideas of what the survival is like?
The durability looks real good in Europe. There are patients over 10 years, and it's looking real good now in some of the very earliest implantations. So very, very good durability. And in fact, it's possible. This is a tissue valve. We've done valve-in-valve procedures. So previously placed surgical valves that have been tissue valves that have re-narrowed, we've been able to put this type of a valve in. So we have hope if we get a good, decade or decade and a half or 2 decades, that we may be able to put another one in if one is necessary. And hopefully you'll get more durability than that, obviously. But
Time with experience will have more numbers and more what to see. But if an individual's 75 and you're going to give them 15 more years,
that's pretty good.
From a heart standpoint, that's pretty good. There's likely to be something else that's going to go wrong for those kind of patients. So it's a significant change, and I'm sure they can be more active and they can feel better and do more things and enjoy their life.
That's the gratifying part. You know, a lot of these patients are patriarchs or matriarchs of very large families, and you're done with the procedure and their colors. You walk back up to the floor, it's dramatic, and that's been really rewarding is to be able to get them back to some kind of a functional status.
And I'm sure that one of the questions that always comes up, it's been around long enough now so that Medicare or most private insurances are going to cover it in some manner at least. So it's not like sometimes when these things first come out, they're investigative and then the insurance company doesn't want to pay for it. And it's
that's a good point. Yeah, it is an expensive procedure. You automatically think that, but this is new technology, so it's not necessarily, really inexpensive just because you did it percutaneously. Actually, it's more expensive because it's new technology. But there are competitors coming on the market. There are different valves being developed, so that will likely come to play.
With the team of physicians, there are costs with just having a team versus a single physician or two physicians. So I can see that would make some difference. But if it's no longer considered investigative, but a real procedure, then for most of our patients, they shouldn't have the worry or the concern about the major expense. And certainly if they're sick enough that they end up spending very much time in the nursing home because they're now so weak and so ill and so short of breath that they can't function at home anymore, that gets pretty expensive pretty quickly too.
Yeah, this is one of those interesting procedures, when we talk about statin medications to lower cholesterol, or we talk about even interventions, and we talk about a term we use, number needed to treat to save a life. And usually it's 80 to 100 for some of those procedures. In this procedure, it's 4. It's pretty remarkable. So this is dramatic. You only need to treat that many to really make a difference. And
so it's got a much better chance of being effective for these patients. And I know that you have had some examples or some little clips that we may be able to show that shows the neat little techniques. It looks very simple, but it's not always as simple as it looks on those little clips. It takes some skill and some training and some experience to get those to slip in where they need to be.
It does, and I think the biggest thing that we've learned is it becomes a choreographed dance. You sort of learn what this guy can do and what this guy can do well, and you let them do their thing, and you don't try to do it all. You do what you do best, and if somebody's better at a certain part of it, you step back and let them do their thing, and that's your best chance of success.
Sure. Well, what are some of the other things that you think that people might like to know about this this kind of new technology? Are there some other things? Is it looking like it might be available for some other valves other than the aortic valve?
Yeah, we can't. If the mitral valve has been operated on before, we're able to put one of these valves in if that becomes a problem. We're one of the few centers that have done that, have been able to do that. But you can do that. There is leaky valves that we're now addressing with a different type of device called a clip, sort of to put on a valve to narrow down some of the leakiness of the valve. And again, all these new procedures are sort of designed for the very high risk, because surgery is still a pretty good thing. Mitral valve repair, for instance, in the mitral area is very good, very durable procedure. But there are patients who the surgeons think, if they're inoperable, well, we may have a device for that valve. But every valve is very unique and very different. So we have to.
So there's some more technology coming behind this one. This is the good one, the new one now for the aortic. There'll probably be some others for some of the other valves that can allow them. And I know when you mention inoperable, everybody thinks, well, they can't do it. Now, that inoperable, usually you and I, to us, that means, oh, the risks, they're just not going to make it out of the operating room. The risks are too high. And I think sometimes patients think that we can do all sorts of miracles. Well, we can do some good things, but not always perfect. And those are the ones you and I say, sorry, we just can't, and used to say far more often, sorry, we just can't help you with this. And we're going to have to do the best we can with medicines and hope that things work out.
Yeah, so when you and I, when we graduated, that's one of the first things they told us in our oath was do no harm. And when you're a young doc, you think, well, of course. But as you get older, you think, yeah, you can hurt people. So you have to be careful.
That's exactly
not to
right.
do too much.
That's exactly right.
So.
Yeah. So I think people would be scared into saying inoperable. Well, then why are they doing this? And it really is the kind that we used to say are inoperable. Now we have a good chance. And as you say, if it's a number needed to treat that's 4 to 1 compared to 80 to 1 in many of the other procedures, that's very, very good numbers. Well, good. Well, thank you, Dr. Martin. It's been enjoyable. It's been educational for me to learn some things that I can help my patients with, and I'm sure for patients, it'll help them see, hey, we have some new things. There's some things that can be done that we couldn't used to do.
Well, thank you. Thanks again for having me.
Sure. Thanks again for being with us. This is Talks with Docs, Dr. Dale Michels, a family physician here in Lincoln who's been joined by Dr. Steve Martin, a cardiologist at Nebraska Heart. And we've appreciated this opportunity to bring this information to you.
Stenosis is the term for a valve that doesn't open properly. Here we see a cross-section of a normal heart from the side and a close-up view of the valve looking down from the top. When the valve is working properly, it opens fully to allow all the needed blood to flow through. In problems like aortic stenosis, the valve doesn't open all the way, so less blood flows through the valve, and the body has a reduced supply of oxygenated blood. Stenosis can be caused by age, or by a malformed valve called a bicuspid valve, where two flaps are fused together, which is present in 2% of the population.